Hi, good morning. I'm Amy Young. I'm chair of the Mental Health Transformation Working Group, and today we have with us Dr. Virginia Selleck. Virginia.
Hi.
Good morning. And she is the project director for the Mental Health Transformation Grant, and Benton Goon is here with me today. He is my co-chair of the Transformation Working Group. We're really glad that you can join us today. Today is our final Transformation Working Group meeting, and it's an opportunity for us to be able to share with everyone who helped with the planning of the Transformation Grant and all the TWIG members and all the consumers and stakeholders that have been a part of making this grant a success. We're glad to have this chance to be able to share with everyone many of our accomplishments over the last 5 years. In fact, there are so many numerous accomplishments over the last 5 years that we're going to try to highlight the main ones in this session. So we're glad that you can join us today, and now we can begin talking about the story of the Missouri mental health transformation. It started in 2006 and is concluding this month. In 2003, the President's New Freedom Commission described the mental health system as a patchwork relic that was disjointed, fragmented, and full of barriers. And so in 2003 of July, the President's New Freedom Commission on Mental Health issued a report that said that today's mental health system is a patchwork relic that's very disjointed, and that this system presents too many barriers that add to the burden of mental illnesses for individuals. And the Commission recommended a fundamental transformation of the nation's approach to mental health care. So these remarks were also echoed by the 1999 U.S. Surgeon General in a report, and then later by the World Health Organization. So the Commission outlined 6 goals for improving the mental health system. The first goal was that mental health is essential to overall health. The second goal is that mental health care is consumer and family driven. The third goal is that disparities in mental health services should be eliminated. Early mental health screening, assessment, and referral to services should become common practice. And the fifth goal is that excellent mental health care should be delivered and accelerated. And finally, number 6, the Commission's goal was that technology should be used to access mental health care and information. So Missouri took these goals and applied to become one of the states to be able to transform its mental health system. And Missouri was one of only 9 states that was selected to develop and implement a comprehensive transformation plan with $11 million in federal funding. Missouri's comprehensive plan set goals that corresponded with the 6 goals that I just read from the New Freedom Commission. Missouri replaced the number 6 goal with the following: Missouri communities are proficient in meeting local mental health needs. The New Freedom Commission's 6th goal on technology, although it was removed from our goals, we interwove that into all of our goals. The next step was 14 public meetings and 64 action items later were prepared, and the work began in earnest, and Missouri Transformation is pleased to report these results. And following consolidation and adjustments over the years, many of the remaining 60 action items listed under the goals that they addressed are the initiatives of the Department of Mental Health that were either kick-started or supported by Transformation Grant funds. Each project is listed under its primary goal, although some projects may address multiple goals. And with the time that we've allotted here today, we aren't able to go into depth on each project, but the following slides will give you an idea of how we addressed each goal. More complete information will be available online once the final update to our comprehensive plan is completed within the next 2 weeks. It will be available on the Transformation website. And Virginia, we can go to the next slide, and Virginia can talk about this slide here.
One of the biggest challenges I think that we had when we tried to describe what our grant was about was getting it across to people that what this grant was for was infrastructure. You say that to people and they look at you blankly like, what are you talking about? So the use of this slide, using the bridge, the point of using the bridge is to demonstrate that just as people need a bridge to get across the river, this bridge is not the service they're trying to get to on the other side. The bridge is simply the vehicle to get there. The work that Transformation has done, we could not use these funds. The federal government precluded us from using the money to provide direct services, meaning we could not buy counseling. We could not hire staff whose job it was to do direct care for people. This was a little confusing to explain, but I would like you to sort of think about how the accumulation of small changes, which is what we have done, and as we go through these the programs that we have done, and at the sort of toward the end of our presentation, we'll actually give you numbers of how many of these different rules, policies, and so forth have changed. I think will help you see that the need for training was acute in many of these issues. Training is an infrastructure type of a thing. And the policies and rules that govern the way we deliver our services are all part of the necessary infrastructure. So really, Transformation was about building a new bridge so that individuals could get from the kind of care that we are receiving now to the care that we know will be more effective. This was a mission of the overall President's New Freedom Commission, and it was in fact what was addressed by all the different states in the Transformation Project. I think we're going to move into now talking about some of these projects. Benton and I are going to kind of bounce, and Mamie all are going to bounce back and forth, giving you some examples and describing some specifics about the projects. You'll see things on the slides that we won't be talking about today, but as Mamie said, all this information is available and will continue to be available if you want more information at a later time. So Benton, I believe you're on deck here.
Okay, so going back to those 6 goals that Mamie shared with you at the first, we are actually going to highlight some of the ones here at the top of this slide, but this is a list of all of the activities that were related to goal number 1, which was America will understand mental health is essential to overall health. That involved 14 action items. 12 of them were sustained and completed and are completed, and 1 was discontinued, and 1 is still pending with work going on. So we're just going to highlight some of the ones that are kind of the flagship transformation programs. The first one being mental health first aid. As most people know, mental health first aid, hopefully know by now, mental health first aid is a 12-hour course that teaches people, everyday people, similar to first aid, teaches the common man on the street about how to identify and help a person in a mental health crisis. It not only, and again, it's been studied, it was started in Australia, it's been studied since it was first developed, and the findings of research around this mental health first aid course found that it not only teaches people skills in how to identify and assist a person in a mental health crisis, but it also reduces stigma, which is we know was one of the major intents of transformation. Missouri is one of 3 partners that has brought mental health first aid up nationally. We partnered with the Maryland Department of Division of Mental Health and Hygiene, which also is one of the 9 transformation states, and the National Council of Behavioral Health Care, which is the trade association for community mental health centers nationwide, and the 3 partners together have brought up the National Mental Health First Aid Program. In Missouri, over the course of the time that we have been in that partnership, we have, as of today, we'll have graduated more than 200 instructors for that 12-hour program in Missouri. We have a course going on right now that has 30 individuals going on in St. Louis. Over 20 of those instructors are for the Department of Corrections, who has taken up mental health first aid and is using it to instruct probation and parole officers, and gradually taking mental health first aid throughout their system. We have been both very proud to be a part of the partnership with that department, and they have turned out some excellent instructors in that program. We also have more than 6 that we have trained for the Department of Social Services. To date, if you believe the national website, there are more than 1,500 people in Missouri that have actually taken the 12-hour mental health first aid course. We know that there are more than that. Unfortunately, we can only count the ones that are in the national site, but we know there are instructors who teach it in their psychology class at a university, and they, for some reason, aren't right now putting that into the national site. We're working with our 200 instructors to try to get them better. But on record, we have more than 1,500 people in the state who have taken the 12-hour course, and over 30,000 people nationally now have taken the course. So, so mental health first aid is taking off nationally. In Missouri, we've kind of have some special focuses that we've focused on with our transformation dollars and our partner dollars. We got a grant from the Missouri Foundation for Health, which allowed us to, and we still are through February, offering mental health first aid courses for faith-based communities. In fact, there's a large number of those being set up right now. The National NAMI and Pathways Behavioral Health are particularly on the forefront of doing those faith-based community trainings. Higher ed, we have, I think, 7 or 8 colleges and universities have actively taken on mental health first aid, and are some already looking to expand their program. The University of Missouri Columbia wanted to get more people into this last course, and it was actually full. So we'll continue to look for funding to help higher ed expand mental health first aid. The Department of Corrections and the Division of Children's Services have been good partners in special focuses of our transformation effort. At the national level, there is continual product development going on. We are in the process of working on a youth version of mental health first aid, which they have in Australia. It is for adults who work with youth. We nationally contracted with Georgetown University to take the Australian version and translate it into the American version, and we are in hopefully the final draft stages of having that manual done, and then we'll actually be creating the teaching notes and all of the things that go along with that. We don't yet have a date going on, a date set to release that, but because it's run longer than we had planned. We are nationally working with WICHE, which is the Western Institute for Higher Education, something, I always forget the total name. And they got a grant, and they're actually helping us develop a Spanish version of mental health first aid. We are working on some 6 curriculum modules, we call them. And what they are is they don't change the mental health first aid training, but they help tailor it to specific populations or groups that we are interested in marketing to. We are working on a faith-based module. Based upon the work we've done here in Missouri, we have developed some, and what it does, it takes some of the activities and some of the examples and tailors them to a faith-based community. We're working on a higher education module that uses more higher education examples. We are working on a law enforcement module. Law enforcement has been very interested in mental health first aid as an adjunct to CIT, because every officer cannot get CIT training, and for those other officers, mental health first aid is a very good alternative. The military module, WICHE again has got some funding from the Department of Defense and is helping us develop a module for the military and for veterans. An older adult module, that's for individuals working with older adults, focused on nursing homes and those kind of workplaces. And then a workplace module. We actually have a national credential for anyone in human resources who takes mental health first aid, and we're working on a specific module so that corporations, companies can provide mental health first aid to their staff, and the examples and the methods make more sense to that population. As far as sustainability, our transformation funding for mental health first aid, actually conducting courses, goes away at the end of this month, or end of September. And we are working with the Missouri Institute for Mental Health. We have provided them funding to staff up and actually do the day-to-day management of mental health first aid in Missouri. And the intent is within the 1-year funding period that they have, that they will be self-sustaining. They will begin to sell enough instructor and 12-hour courses to help sustain the program. We have also received our first royalties off of our national partnership, $1 a book that we get for every manual sold nationally, and that also will help sustain the Missouri program. So that kind of covers mental health first aid, and was kind of long, but it is indeed one of our flagship programs. The second thing I wanted to talk about was respect, and I know that many of you have seen our respect speakers. Respect was started by an individual called Joel Slack, who runs Respect International. Joel is himself a consumer and delivers a powerful speech about how respect was so important to his recovery. And several years ago, started working with Fulton State Hospital to develop what was called a Respect Institute, which taught consumers there to tell their story. And they then went out and spoke in schools and civic meetings and did orientations for staff there. And we wanted to expand that statewide, because what we found again was it increased the understanding of people with mental illness, and it also helped reduce stigma, which was one of our major goals. So we worked with the other existing state facilities in Missouri, state psychiatric facilities, and it turned out over the time 10 community mental health and developmental disability providers have also taken up respect speakers. And we created, working with Joel and Fulton State Hospital, we created a Respect Institute, and then created a Graduate Institute, because if you hear Respect Speaker and then you hear Joel, there's a difference. When Joel speaks, you walk away with no doubt that the core of his message is the importance of respect in recovery. And so working with Joel and working with our Respect speakers, we identified some speakers that Joel has worked with to teach them how to make respect the center of their talk. And so that's been great. And when Joel, we knew that Joel would go away and the transformation funds wouldn't be there, so as part of that process we developed a manual. We trained respect coordinators and trainers in every one of those programs, so respect will continue on and grow after transformation goes away. The places that we have respect speakers and institutes and coordinators are Northwest PRC in St. Joe, Fulton State Hospital, St. Louis PRC in St. Louis, Southeast Missouri Mental Health Center in Farmington, Southwest PRC in El Dorado, and Center for Behavioral Health Medicine in Kansas City. We also have 10 community mental health centers and other providers that have taken up respect, and even though they were not required to, they said we want to have respect speakers, and that includes Ozark Center, Pathways, ADAPT, BJC, Independence Center, New Horizons, Swope Mental Health Center, Truman Mental Health Services, Comprehensive Mental Health Services, Tri-County Mental Health Center, and then on our own, Incorporated, which is actually a independent living center in Nevada that serves people with developmental disabilities. To date, we have 209 respect graduates statewide, and we ask them to tell us when they do speaking engagements. They have at least told us about 477 of those in the last year. We again think there are more going on that haven't entered our system yet. But as some of the examples of places that they are speaking is secondary and higher education. They are very popular in both high schools and college classes. Staff orientation to their own facilities and centers where they are located. Police academy and probation and parole officers they've spoken to. Service organizations like Kiwanis and Lion Club and all of those, and faith-based communities. So again, they are out there. They are very popular. If anyone is interested in having a respect speaker, you can call the department here at 800-634-9687 and ask to speak with someone about a respect speaker, and they will link you up, and there is no cost for a respect speaker. Certainly they would welcome covering travel expenses or those kind of things, but these individuals do this voluntarily because they think it is the right thing to do. Next, the Missouri Foundation for Health. That was one of the things that again was started with the Missouri Mental Health Foundation. That was one of the things started using some of the transformation funds. It works with the Department of Mental Health to help it fulfill its responsibility for public education and stigma reduction. Some of the things that it is actively doing right now is it is the sponsor of what is the Mental Health Champions Banquet, where annually they recognize mental health champions representing each of the 3 divisions of the department: people with developmental disabilities, people with mental illness, and people who have overcome substance abuse issues, and they are identified as champions for the things they have accomplished in their recovery. And they also identify mental health legacies, those individuals who have had a great impact on improving mental health care in Missouri over time. And that banquet, the next banquet that they will be holding is in June of next year, and if you haven't gone to one, I encourage you to go. It's a very uplifting kind of conference. They also are involved in helping the Real Voices, Real Choices Consumer Conference that I'm going to talk about later. And they are in the process of developing other anti-stigma and public education campaigns. For more information about them, you can go to www.missouri.mhf.org, which is their website. And then finally, the tobacco prevention and cessation. As we all know, people with mental illness die 25 years earlier than the general population, but they die from the same diseases as the general population. We also know that people with substance abuse and mental illness are amongst the very highest users of tobacco products. So working with the Missouri Foundation for Health, we received 3 grants over the last few years from them around tobacco cessation. The first grant really was one to conduct a needs assessment, and the Missouri Institute for Mental Health actually did that needs assessment, surveying providers to find out the tobacco use and the needs for cessation programs. Then after that was successful, and we received a grant to develop a plan for cessation programs in Missouri, mental health programs. And we were just notified, and then that was successful, and we just received word this week verbally that the department will be granted a 2-year $243,000 grant to pilot 2 community mental health centers and 1 substance abuse treatment center in a cessation program based upon the plan that was developed. Those 3 centers will be Comtree, Kreider Health Center, and Queen of Peace Center, all in the eastern region. And implementation of that grant will start in November. So again, I think we are making first steps to reduce tobacco uses amongst the population and improve health status for that group. Virginia.
No, this is me.
Mamie.
Yes. And in the interest of time, I do know this website. If you go to the Department of Mental Health's website, you can find more information about our Health Home Initiative. I do want to talk briefly about the FQHC, CMHC projects that have been going on. I didn't have the opportunity to be at the Department of Mental Health when this grant started. And one of the things that I learned when I came over in 2009 was what a problem it was for primary health care and behavioral health care to be treated so separately and very fragmented, and having various doctors and physicians and caregivers and multiple trips to the emergency room, and I learned about what a problem that was. And I've had the opportunity to shadow Dr. Joe Parks, who is a leader nationwide in integrating efforts to integrate behavioral health care with primary health care. And one of the opportunities that I've had to assist him with has been the Affordable Care Act's Section 2703 health homes for persons with chronic illness. And under the Affordable Care Act with healthcare reform, states have the opportunity to file state plan amendments to become healthcare home providers so that you can try to have better care coordination for people with chronic illnesses. And in Missouri, the chronic illnesses that were based on the Affordable Care Act, but the chronic illnesses that are going to be recognized under the health home are things like asthma, diabetes, cardiovascular disease. Substance abuse is considered a chronic illness under this, and also serious mental illness and developmental disabilities. This is across the lifespan, so there's not an age limit or age range. This is from birth to senior citizens, and we are hoping to be able to better coordinate care. The Coalition for Community Mental Health Centers have been working with Dr. Parks, and a state plan amendment has been filed with the Centers for Medicare and Medicaid Services, CMS, to be considered a health home state. Missouri was one of the very first states in the United States to file one of these applications. So when I say Dr. Parks is a leader, he has helped Missouri to become one of the top states in the nation to take this step for this initiative. The Primary Care Association has also been working with Dr. Parks, and they have a parallel state plan amendment that has been filed to try to help care coordination. And these two initiatives will try to keep people from having multiple emergency room visits, trying to get people associated with a community mental health center if they need it, trying to get more behavioral health care implanted within the primary care system, and then on the opposite side, trying to get primary care like nurse practitioners and physicians embedded within the community mental health center so that there's a link there between the two. There's also a disease management 3700 project that the Department of Mental Health has been working on with the Mo Health Net Division. And one of the things that I've been really impressed by with being over here at the Department of Mental Health is, and this is probably unique to Missouri, is learning about what I think we have a very good relationship with the Department of Mental Health and our Mo Health Net Division, which is our Medicaid division for the state. And Dr. Ian McCaslin at Mo Health Net and Dr. Joe Parks have a very good working relationship, and I think that has helped give Missouri that boost so that we can work together. But the Disease Management 3700 project was an effort to try to target individuals that are high risk, that have high needs as far as emergency rooms and their their conditions who are not associated or affiliated with a community mental health center. And so trying to get these people connected with their local CMHC and get the care and coordination that they need to prevent and to reduce the number of unnecessary ER visits. And so far that program has been very successful and is ongoing. I'm continuing to work on things with the Affordable Care Act and healthcare reform, and the timing of healthcare reform during the transformation grant. It was just, fairly good timing, and I was able to focus on different things under the Affordable Care Act that would help transform the mental health services, and I am going to continue to do that going forward beyond the term of the grant. So that is something that will be ongoing.
We'll turn our attention now to Goal 2. You will see there a long string of things. I'm going to speak about the first 4 in particular, but I want to say that the whole point of this grant, obviously, the whole point really of the mental health system ought to be focused on the people who are receiving the services. What we know now in this century, or this part of the century, is that people's active participation in their treatment and families' active involvement are things that really lead to success and lead to wellness and health. There's a phrase that many of you probably have heard already that the consumer movement in the country uses, which says nothing about us without us. The idea being that people should not be passive recipients of stuff that other people do to them, that they should be actually involved in every meaningful way. Of course, people have choices and people have different points of view about how involved they want to be. Not everyone wants to work in the mental health system, or not everyone wants to sit on a board and direct how the place operates and so forth. But what we believed and what transformation did was to take an inventory of all of the opportunities that Missouri offers for individuals to be participating at whatever level they might be interested in. There are several areas that I want to target here. The foundation, though, of whatever we do with consumers needs to be around person-centered planning. It's the second bullet on the list. And Lois, if you want to go to the next slide, there you go. The person-centered planning is really the hub of it all. It's the linchpin. People need to be fully aware of and involved in their own treatment planning, and that has required specific efforts with staff members to help look at how records are kept. Again, this is one of those boring infrastructure things that we speak about, but how you write about people and what you put in a plan has a lot to do with what actually occurs for the person. So the person-centered planning involvement that we did was a grant that was an interlinking grant with transformation, and we worked on that with the Developmental Disabilities Division. 3 other things that have gone on which are very important. One is our peer specialists training and certification. I want to explain what peer specialists means. It's not just hiring someone who's had a lived experience to work in your agency. The point of a peer specialist is the purposeful use of a person's lived experience. It is a person who can use their own path, their own journey, and be able to share those things that happen to them in a targeted way with their peers, with individuals with whom they are working. This is a job description that is different. It is part of the array of healthcare givers that there are, but it is a special and unique type of job. What we did in Missouri as part of the transformation grant was to provide a lot of training. We managed to train 209 peer specialists. 133 of these individuals have been certified. This requires the curriculum, experiencing the training and then taking a test to be certified, and a number of them are now working in the community. Those people provide more, in my view, than just the work that they are doing with their peers. They're being able to share their own lived experience, but it's also very enlightening and instructive for their fellow staff members to work alongside people who have passed through their own difficulties, and you can see that recovery is actually a real thing. It's not something that we talk about as a buzzword. It actually occurs. So having people work side by side with peers makes a big difference in showing that happens. Similarly, our family support specialist training has also worked with family members who also can be helping other family members as their children are needing to go through various types of mental health care. We've had 32 of those individuals trained, and we currently have 26 of those individuals working. Part of the infrastructure, again, that was done in order to make this a reality was to get a Medicaid rate for reimbursing agencies to hire these people. It's all well and good to train people and send them out there, but if you have no way of paying for it, you can't do it. So this is a sustainable and sustaining part of transformation that we have done. The Consumer Operated Service Program, COSP for short, is another example of how we have blended the forwarding of an emerging evidence-based practice under the umbrella of transformation, working with the Missouri Institute of Mental Health's Dr. Gene Campbell, who is a nationwide expert on consumer involvement. And what happened here in Missouri was that, like other states, there are drop-in centers, places where people who have serious mental illness have gathered. This happens, has happened throughout, probably the last 50 years around the country. But consumers have come to realize that there's a special thing that can happen in these consumer-operated programs, and through the work of Dr. Campbell, doing research, they have identified what are called the common ingredients that make a difference in a person's recovery. So people are not just sitting around having coffee and watching movies together. People are working actively, and it is directed totally and run by consumers. This is not part of our mental health system, the formal mental health system. It is part of the informal mental health system. In Missouri, we have 10 different types of those consumer-operated programs. 5 of them are centers where people go, and 5 others are warm lines where individuals receive calls if they need to talk to somebody. The consumer-operated programs in Missouri now, along with others, have been added to the Registry of Evidence-Based Practice as an emerging practice, and we are very proud that Missouri's had an opportunity to take part in that. We are devoting more and more attention to bringing consumers and family members into all levels, really, of what we do to make sure that we're doing the right thing. Because if you don't have the consumers and family members giving you the kind of feedback that these opportunities provide, you just aren't always sure. So, and it's resulting in good outcomes. I think that's now for you, Benton.
Okay, and then also related to the same issue, back in November of 2008, we got a group of 100 consumer, family, and youth together in St. Louis with the department leadership, and listened to them and said, "Tell us what you want. What are the things that, as a group or individuals, you all are interested in, and from the department?" And of course, one of the things they wanted was for the more interaction with the department, more conversation with the department, and they also wanted to have an annual conference where people could come together, consumers, family, and youth come together and share and learn from each other. And out of that grew the annual Consumer, Family, Youth, and Leadership Conference. And it's called Real Voices, Real Choices. And the neat thing about that original summit was we were kind of reluctant when we said we were going to bring people from developmental disabilities, people from ADA, and people from CPS together, because we thought they would say, well, we don't have anything in common. Why are we all here? And we want this and they want that. And they did just the opposite. They said we have more needs in common than we have differences, and we can learn from each other. And so they wanted this conference, and they started the next year, the first annual Real Voices, Real Choices conference that was totally consumer, family, and youth planned. They set the agenda, they contacted the speakers, they created the entire conference. And this past August, they held their 3rd annual consumer conference, Real Voices, Real Choices conference at Tantera. They had 450 participants in that conference. And I got to tell you, I've been to every conference since it started. And the first year or two was kind of like they just enjoyed getting together, and they tried to kind of figure out, well, are there differences between people with substance abuse issues and people with mental illness? Do we have different issues? all the way to this year, which was a very sophisticated conference where they had workshops on employment, on housing, and I did the ending session asking them, what did they learn and what did they want next year? And I mean, people came up. I've been to professional conferences that had a less sophisticated discussion than was held, I think, at that conference. So, it is just wonderful to see how this group of individuals have come together and formed a bond that I think will carry the consumer, family, and youth movement forward in Missouri for many, many years and create a very sophisticated group of consumer, family, and youth that can speak to policy issues and those kind of things. So it was, if you ever get a chance to go, it also is a renewing kind of conference. It really makes you understand why you're in the business that you're in.
And speaking of employment and housing, as Benton just said, individuals at this conference talked about employment and housing as needs. These are things that formed a real core of what we worked on in transformation. And of course, every time we talk to consumers and family members, they say that those are the things that are important to them, just as they are the things that are important to all of us. What you do and where you live are, the two most sort of daily things that happen to anybody. So I want to spend just a few moments talking about both of those things and what transformation did about them. In the employment area, it's important to know that people with mental illness around the country, nationally, we are only about 21% of those individuals are employed. Smaller numbers of people with disabilities in general are employed. And here in Missouri, we took that very seriously with the transformation group. As it turned out, we were also simultaneously working with an evidence-based practice called supported employment, which I know many of you may be familiar with, which is a specialized way of assisting people to get back to work. We collaborated with that grant. We have 6 sites in Missouri now who are providing evidence-based supported employment, and they are providing enormous success for the individuals that they're working with. What we also did as a result of this, we had a large employment group that crossed divisions and departments here in Missouri, and out of the result of that were some recommendations that we should, all departments, take a closer look at how we are handling employment. Here at the Department of Mental Health, we have now an ad hoc employment group that reports to Dr. Schaefer quarterly, our director, to look at what we are doing both internally to assist people to work here at the department, what we are looking at in terms of rules and policies that would preclude people from working in the community. One of the biggest barriers to work for people with mental illness who are receiving benefits such as Medicaid or other kinds of subsidized things for housing and so forth, if you are uncertain about what will happen to those benefits if you return to work, you're very disinclined to do it, even if you think you want to. So one of the transformation projects that we are now doing is working with the Disability Council on a web-based tool that is being implemented in 4 other states and will be starting here in Missouri probably in the winter. That is called DB 101, that stands for Disability Benefits 101, where anyone will be able to log in at any computer terminal. You don't have to have a special password or any of that. People will be able to plug in their own information and will find out right away what will happen to their particular circumstances if they are to return to work. That information is power because there are many work incentives that people are not aware of. Many more people can be working and not lose their benefits than they know. And so that's part of what we're attempting to do. There's a lot of training that goes along with helping people go back to work. In the past, people felt like you had to go through sort of some series of steps and that people were asked to start working maybe in a group setting, and then they had to move on to another kind of setting that was not maybe the kind of thing that they particularly wanted to do in practice type jobs. What the research has shown is that the best way to help people get employed is to start with what they want to do and support them on the job. So as more of our staff and more of the programs in the community are learning how to do that, it's resulting in further employment outcomes. Once again, you have to be able to pay for it, and unfortunately, this problem is not totally solved and won't be until it gets solved totally at the federal level, because we have certain differences between what the vocational rehabilitation people can pay for, what mental health can pay for, departmentally, we are somewhat bound. This is a policy issue that is getting attention at very high levels at the federal government as well as here, and we're making inroads in it. We're collaborating with our MoHealthNet partners to be clear about what is appropriately billed for under our Medicaid billing schemes, so that people can get as much support as they can in the employment context. That is something that everybody should take an interest in. It used to be that people didn't think that the mental health system really had too much to do with employment, when in fact it is integral to helping people recover. You don't need to wait until you're recovered to start working on working. Working helps people to recover, and that's really the foundation of what we've tried to do with our efforts in the Transformation Project. Housing is another area of huge interest to people. There are now some opportunities for working with developers using low income tax credits, where our community mental health centers can partner with developers. This is an emerging opportunity, and part of Transformation's work has been to endorse and support the creation of a toolkit describing what mental health centers can do in order to help people get housing, both creating the housing in terms of developing it from the ground up and providing supports to people who need them for particular types of housing. Transformation just a couple of weeks ago hosted a housing summit that brought together many developers from the state of Missouri with mental health centers who are interested in getting into the housing arena. Another thing that we know is that there are people living in congregate settings in Missouri, and some of those individuals are not getting maybe the best treatment that they could be getting there because the staff working there are not as trained as they could be. So with the collaboration of the Missouri Institute of Mental Health, we've created some training DVDs that are now being tested by some residential care facilities in the southeastern part of the state. We want to make sure that individuals who are working with those folks have an opportunity to get training so that on the spot they can be as compassionate and as skilled as possible to help individuals who are in those settings. We expect that this housing and the employment areas are growth areas, really, for the department. And those are things that the work that Transformation has done both around the infrastructure development of changing billing, creating policies, creating toolkits, will really enable us to make the grant effects last far longer than our time. I think now that Mamie has some things to tell you about.
Yes. I've been involved with some early childhood initiatives. I actually sit, in addition to being on the Transformation Working Group, I am also a member of the coordinating board for early childhood here in the state of Missouri. We've had several things that the Transformation Grant has assisted with. One of those is Bright Futures, and Bright Futures has been an experiment to use the public health model for mental health in a community. There are 3 Bright Future sites. One is in Rolla, one in Joplin, and Moberly. And each site has completed one project and is now working on a second project based on their learning from the first, and will implement that program. The Transformation funding is ending, but the Missouri Foundation for Health will continue its funding until May 2012. Currently, there's work being done on ways to sustain the projects, and the Bright Futures projects collaborated with the University of Missouri to use the community issues management as a way to gather community-specific information to guide their work using the public health model. CIM is a web-based system that consolidates and maps data, and they are exploring possibilities for expanding community issues management throughout the state. For early childhood, as I mentioned, I am on the coordinating board for early childhood, and the Office of Transformation has been involved with the ECCS, Early Childhood Comprehensive System, to integrate their efforts into the work of the Comprehensive System Management Team. We've been involved with DESE and other child-serving agencies, organizations, and providers to prepare an application for the Race to the Top for an early learning initiative. And this is something where DESE is the lead agency. And if there's funding, there will be funds for training, et cetera, to create a system where young children will be prepared to start school and be ready to learn and have better quality programs. Real quickly on school-based mental health systems or services, we're actively working with DESE, the Department of Elementary and Secondary Education, and Medicaid to increase funding streams and the options for school-based mental health services in schools. And with changes in personnel at DESE and Medicaid, the plan is to continue the efforts and building on the work that has already been done.
Okay, and Mamie covered one spectrum. I'll go the opposite. One of our flagship programs around older adults, mental health issues of older adults, which is an underserved population in this state very much. And again, we knew we didn't have great dollars out there in the future that we could sustain a big program. So what we actually did was we identified a program called Healthy Ideas, which actually teaches case managers from like area agencies on aging who go into people's homes to assess, educate, make referrals, and do behavioral activation plans for people that they see, older adults who exhibit evidence of depression. So it helps them identify people living in their own home who may have depression, and they also have a clinical coach from the local community mental health center that they can interact with and identify methods to help do behavioral activation plans that have been shown. This is an evidence-based practice, has actually shown that it does help to raise a person out of depression many times without medications. We worked with 6 AAAs throughout the state and 1 community mental health center and trained 45 of their staff in Healthy Ideas. And then we trained about 20 community mental health staff, and not only Healthy Ideas, but how to be a clinical coach. And out of that, we also trained 7 community mental health staff to train on Healthy Ideas. Because again, we knew when transformation went away, there wouldn't be a way to bring trainers into Missouri, so we actually got those trainers certified. So as other agencies become interested in Healthy Ideas, we have trainers right in Missouri that can provide that training. So Healthy Ideas has been implemented in 6 agencies. The Missouri Foundation for Health recently granted some also grants for aging and mental health services, and 3 of those agencies that got those grants are going to implement Healthy Ideas. So we feel like this has been a successful start to grow what we think is a very services to a very underserved population of older adults living in their own home, many times suffering from depression and going undetected. So
the essence of these 2 projects really is to identify individuals who had high use of mental health services and physical health services, and how to target and help those individuals with using data mining techniques in some cases. And Mamie mentioned some of the work that she's been doing around the healthcare homes. This was sort of a precursor project to that. The essence of it here was to really figure out who was using what service, figuring out if people were using services erroneously because they were being misdirected or were not being helped at an earlier time in their problems, and getting really one of the things we did in this project that has helped build the foundation for the healthcare home was to do individualized staffing about individual particular consumers, looking at bringing together groups of providers and looking for systems breakdowns. Where did the ball get dropped, basically? And in doing that, the Eastern region, as part of what they have done there, and we'll say a few words about them later, created close collaborations between local mental health partners to correct the system breakdowns and use data to track what happens to people. We're running short of time, so we're going to move right along here. Evidence-based practices work group and evidence-based practice implementation. You've heard those words, evidence-based practice, throughout this conversation that we have had. The key features to know are that There are things that work better than other things. That sounds like it should be pretty obvious, but it has been a difficult change in the field. For years, people thought the best that was going to happen for folks was to have maintenance and stay out of the hospital and so forth. Years have passed, research has been done, and it is now clear that in many domains, particular types of care makes a huge difference in whether people recover or not. So the purpose of our evidence-based practice work group partly was to simply define what is the meaning of evidence-based practice. It was not to create a list of what they were, because if the world goes on the way we want it to, there's going to be new ones happening all the time. But what we wanted to do was to define for the state, what did we mean by evidence-based practice. That paper is now available and is on our website. Evidence-based practice implementation, that is to say, doing the actual practices that we have identified, requires training. It requires fixing the rules and policies. It requires a lot of change. We all know, I love to say it, no one loves change. Even a wet baby screams through being changed, and so do our providers, and so, yes. So what happens here is that we have got to bite the bullet and be willing to notice when we are doing a thing that is not as effective as something else would be, and that is really the bottom line here. Everything that we are doing or trying to do shifts the system toward doing it better, better results, cheaper, etc.
Okay, and quickly, using the using technology was a big issue too. And one of the things we wanted to get was a common state identifier across all state agencies. We came up a little short of that, but the Department of Mental Health, Social Services, and Health and Senior Services did adopt a single identifier. And really the work of single identifier now has moved to the health information exchange discussions that are going on. Electronic medical records centered around electronic medical record for state facilities, and actually an RFP was just awarded, and we will be implementing electronic medical records in our state facilities over the next several months. E-learning is a big issue. Both College of Direct Support and e-learning at the department are implemented. The Department of Mental Health currently has over 730 online e-learning classes that are being provided to all of our state staff and to some contract staff in our developmental disabilities world. Also, the Division of Developmental Disabilities has what they call the College of Direct Support, in which they provide 35 courses to over 3,000 people, and those courses focus on direct care staff and the skills that they need to become better direct care staff. So, I think we're doing.
We missed a slide.
Yeah,
Communities of Hope. That again was another attempt to work with local coalitions to take a more public health approach to mental health. We awarded 6 grants, small grants of about $30,000 each to some regional centers. We required that they work with existing coalitions to expand what they were all. Many of them were substance abuse prevention coalitions. We asked them to expand and begin to look at mental health issues. They did community assessments, looked at data, came up with identifying what are the needs in their area, and those groups have taken an interest enough. I think most of them will continue without funding to look at mental health issues in their community. Each coalition developed a mental health and wellness plan for their community. Several of those coalitions introduced mental health first aid into their community. One county actually, as a result of their work, approved a mental health board in their county, which is the first step towards getting a mental health meal tax on the ballot. One coalition is addressed depression amongst women and girls, and a couple of them focused on teaming with local aging groups to improve mental health in the older adult population.
The eastern region of Missouri has formed sort of a demonstration of trying to address all the stuff that Mamie mentioned at the beginning about the fracturing, the disconnection, the barriers, all of that. Since the beginning of transformation, that particular part of the state has worked with each other, including hospitals, community mental health centers, shelters, family members, consumers, advocates, to bring together all of the parties. Over these years, there's been many manifestations and meetings and working on this, and it has really resulted now in the Eastern Region Behavioral Health Network, which is working on specific housing initiatives for that region that will transcend providers, and specific work to make certain that all voices are heard and that there is a sense of organization that we hope will be a model that can be used elsewhere. And we are very heartened by the fact that people who in the past were working in the same neighborhoods and may not have known each other now really do, and that the consumer and family voice in those projects is moving us forward rapidly.
We've had many overarching themes throughout the last 5 years of this grant: consumer involvement and making sure consumers have a voice, stigma reduction, integrated care, and the adoption and promotion of evidence-based practices.
So what has changed? We had to keep track for the federal government of a lovely thing called GIPRA, which I think means government reporting and something. We had to count pretty much everything. We have summarized for you here briefly some of the actual numbers of things that have actually changed here. As you can see, more than 18,000 individuals have received training, 93 policy changes. We are in the process of implementing at least parts of 6 evidence-based practices. We have changed 3 state statutes, changed rule, and have had numerous budget items approved. These are the infrastructure counts that we believe are going to lead ultimately to the real improvements in service delivery at the consumer and family level.
Evaluation?
Yes.
Okay. Real quickly, we were required to do 2 proof of concept studies. One had to look at adults and measure recovery. Another had to do with children and measure resilience. And you had to pick a something that hadn't been a new thing that was being implemented. So for adults, we picked peer specialist program, and we compared people who got services from a peer specialist with individuals who did not get services from a peer specialist. And the early evaluation information about that is that we see an almost, it was shortened. It was supposed to be a year-long study, and because we got thrown in with the states that got the award a year before us, we only had 6 months to do our follow-up study, and we thought we would not see much change. And indeed, what we saw was an almost statistical significance of improvement for people who got peer specialist services compared to those people who did not. On the family support one, which was looking at children who received services from a family support worker, we did not get significant results, but the numbers were much lower. And again, the time period that we looked at was very much shorter than we anticipated. We are doing a number of local evaluation, and MIMH is working on those over the next 6 months. We will be rolling out the results of those evaluations, and we'll make those available to everyone, so that we're seeing very positive results. They're actually going to, after the webinar, do a little report on the early findings, but we will be rolling those out. And then the cross-site evaluation, that's where a federal group actually looked at the 9 states and compared the 9 states that were doing transformation. We have seen a draft report from that study, and we are not allowed to release that draft report because SAMHSA has not released it. But what I'm going to tell you, if you promise not to tell anybody else, is that Missouri consistently came out as one of the top 3 states in achieving the most outcomes, the most goals, the most activities with the fewest amount of dollars. And that goes to our next slide, which is all of the partners that we could not have done someplace on here is a partner. All of the partners, it was because, and we got credited with this, is we leveraged transformation dollars. We didn't throw transformation dollars in by themselves. We looked for other people to partner with, and that is why I think Missouri made the most out of its transformation dollars and looks very good against the other 8 states that are out there.
So the story continues, and we're all called to action. Remember, as we move forward, mental health first aid, respect, healthy ideas, housing and employment, to healthcare reform, tobacco cessation, and evidence-based practices. As I mentioned, September 30th, 2011, which is next week, is the official end of the Missouri Mental Health Transformation Grant. We do have an extension that's using unexpended funds that has been approved to wrap up projects through March of 2012. Most staff funding ends September 30th, 2011. But we want to thank everyone. Thanks to all of you all who have taken the journey with us. And thank you for joining us today.